dan maju bersama dalam tatanan baru UT-PTN-BH.
Yes, good afternoon, Prof.
So shall we start the session? Are we waiting for someone else?
Okay, sorry, Prof. We wait for Halim.
Okay.
Hello, Prof. Azimatun. Can you hear me?
I can't hear you clearly. It's actually sounds so far.
Oh, now it's better.
Yeah, it's better.
Okay. Thank you.
Recording in progress.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good afternoon, ladies and gentlemen. Welcome to the e-lecturing event held by the Public Financial Accounting Study Program. This e-lecturing will be held today, and the second event will be held in Friday, November 3rd to 2023. Here I am, Halim Dedy Perdana, will be the master of ceremony and moderator for this activity this day and the next Friday. So in the first time, let us start this activity by singing the song of Indonesia Raya, and after that, song of the hymn of Universitas Terbuka. Ladies and gentlemen, this is the national anthem of Indonesia. Okay, thank you. Now, before we start the main event, we can take a picture first. So, for all of the participants can open the camera for the photo session. Okay, Mbak Nadira, can you help us to take a picture? Okay. Okay. Thank you, all of the participants. Now, furthermore, because the head of the study program was unable to attend for this activity today, we immediately started this activity with the main event. The main event is today we discuss and talk about the financing and developing a healthcare cost system. This is a interesting topic, interesting theme. So we can share, we can discuss. You all of can give feedback, can give summarize this theme, because I think the healthcare in Indonesia, especially, is very complicated problem. Yes, maybe like Malaysia, Prof. Azimatun. So
Not
we can
really.
share about.
Don't worry, we can learn together.
Okay, okay. So before I introduce Associate Professor Dr. Azimatun Aizuddin, she is a trained medical doctor, earned master's and PhD in community medicine. She is a public health consultant and currently the head of International Center of Case Mix and Clinical Coding, HCTM, besides as a senior lecturer at the Department of Public Health Medicine in Faculty of Medicine, UKM. She is also a former assistant editor of International Journal of Public Health Research and reviewer of a few journals locally and internationally. Besides that, she has published more than 50 papers locally and abroad, as well as a book chapter, and has presented more than 50 papers and proceedings locally and abroad. In addition, she is a member of Technical Advisory Committee for Health Technologies Economic Evaluation, Technical Advisory Committee for Case Mix, Technical Committee members for ICD 11 implementation, External Reviewer for Scientific Review Board, Institute for Health System Research, Reviewer for Public Health Specialists, NSR CBD Point, and the last honorary treasurer of Malaysia One Health Network University Pro Team Committee. Wow, it's very long
TV.
experience, yeah, Prof. Okay, Prof. After this, maybe in the 30 until 45 minutes is yours, maybe. Thank you, Prof.
Thank you very much for the lengthy introduction. So I would like to actually share my slides. So I just want to ask whether all the participants can hear me clearly, because just now I noticed there is a few participants can hear the song. Is everybody can hear my lecture clearly?
Okay, it's clear, Prof.
Okay, thank you very much. So we are downloading the, and as I try to actually make myself smaller. Okay, so if everybody can hear me clearly, so I think I can proceed to our session or lecture. So the topics is actually more of I try to as much as possible keep it general, because when I look at the curriculum or I look at the objective, there is too many things for me to put inside my slides. But I reserve it into the presentation. Then, in fact, I divided into a component. So I'm going to actually talk about the health financing. So inside the health financing, we are looking at the system and everything. Then the next, I have two versions of the curriculum given to me. So the one that I actually referred to is actually this session is for the health financing. And the second one is actually more about the budgeting or costing. So I split the health economy calculation into the next session together with the budgeting system. But budgeting system is also inclusive of today's session. I try my best actually to talk in English because my slides is English. However, if you don't understand or you want me to talk in Melayu, bahasa Melayu, I think I can also mix up, especially during our discussion. Yeah. So I think we proceed to the lecture. So as introduction, when we talk about the health financing, we actually talking about the ability of the health system to maintain and also improve human welfare. So especially the health of the populations. So, and it's actually the health financing is the function is actually function of a health system concerning with the mobilization, accumulations, and also allocations of the money to cover the health needs of the population, individuals, and also collectively in the health system overall. So, and its purpose is actually to make the fund available as well as to set the right financial incentive to the providers, that means the hospital, in the clinics, and etc., to ensure that all the individuals have access to the healthcare. So I'm not sure why I can't see the full of the slides. Never mind. So I think that is about the introduction. So furthermore about the introductions, as we know, so now we have economic crisis. Yeah, that's worst of the things being discussed. As a beginning, so since 1990s, this health financing is actually a sensitive issue discussed worldwide. Then it's actually the important needs of why we're discussing this is actually to maintain deserving health for all, and also to overcome several problems in the cost containment in the healthcare. As we know, the healthcare cost is increasing in tandem. So every government actually will never afford to continue to use their percentage of GDP to help to provide the best health for their population. So due to this inability of the states of the health sector to deliver cost-effective and user-friendly services to the whole population, most of the nations are looking at ways to contain the healthcare expenditure by whether the private or publicly funded system. And in fact, there is also a trend of revolution in the healthcare provision and also financing. And this is actually, when we talk about this, we are talking about the universal coverage. So every country in the world is looking at what is the best way to cover the whole population, as the term is a universal coverage. So, excuse me, I think I need to change my slides because it's come out like not as it's supposed to be. So I stopped sharing for a while. If I stop sharing, see, I need to take up from the another side. Sorry, technical problem. Download it again. Let's share it again. Okay, so let's look at the next slide. Oh, it's the same. Oh my God. So I cannot share. I cannot share in advance. So I need to change to it to the lecture notes. Something wrong with the slides. Okay. Sorry, I can't share it in advanced mode. I need to share using a basic mode. Okay, can every one of you see my slides now?
Yes, Prof.
Okay, so we are talking about the universal coverage just now. So why is actually our healthcare is actually cost is actually increase in tandem. The first thing that why is the healthcare cost is actually high, very high, is actually because the advanced medical technology. So we cannot avoid from having this advanced medical technology because these advanced medical technologies help us in the treating of the patients. So in fact, with these advanced technologies, makes our populations being treated, and in fact, the population live longer. So currently, most of the countries actually facing towards the elderly populations. So when there are about elderly populations in the country, there is a changing of disease patterns. So in which that previously, with a younger age, people don't have so much of the chronic diseases. So with the elderly populations, we are facing double burden of disease pattern. So first, we have the chronic diseases because of the elderly populations, but we don't actually recover enough with our infectious diseases. So we have double burden in terms of chronic diseases and also acute diseases. So most of the country in the tropical region still facing the infectious disease. And in fact, now with the COVID and SARS and etc., we have not just the current infectious disease, we also face the emerging disease, re-emerging disease and etc. So this actually further increase the healthcare costs. So when we look at the real growth of the what happened in the world, so we can see that actually the health spending is increasing and it's not proportionate with the GDP that's spent for the health. So in which that we are spending more from what we have money for our health sectors. So when we look at the health system, okay, So when we talk about this whole concept, we need to look what is the health system is all about and what is the health system that is really been implemented worldwide. So when we talk about the health financing system or scheme, it's actually the methods of the specific countries acquiring funds for the funding of the healthcare system. It seems to be like very simple, okay? But and also there is so many methods that we can use, okay? However, implementing it and also evaluating is actually not that easy, okay? The first process developing it and also assessing it is actually have a hassle inside it, okay? So it's not just pick up the system and use it for the country, okay? It's not that easy. So what is the roles of this ensuring the healthcare financing? Yeah. So healthcare financing actually play a role in terms of why we can't just pick up any health financing, because we want to choose which one is actually the best role for our population. Which one gives the best protection and also safety? Which one gives the equity and efficiency? Every country will have different equity and also efficiency, and still maintain the sustainability for the populations. So this is why actually we need to know how to choose and what to choose in the health financing system for the country. So, however, okay, it still depends on the perceptions of the local community. My experience doing my PhD goes to the house-to-house survey about their perception about the healthcare financing. Not many population actually knows what is actually the healthcare financing. In fact, they just accept whatever it is. So, but when I explain to them to give them the scenario what is actually the healthcare financing, then only they can catch what is actually the healthcare financing. Then only they can give their perceptions. Okay, what they know is actually the healthcare is free for them. Okay, so that is the things that we also need to look, and we need to also survey and also need to ask our population what is their knowledge and what is actually their perceptions in terms of how they want to have the healthcare financing is and how they want to have the healthcare services. So there is so many healthcare financings in the world. Yeah. So for example, most of the countries in the Asian countries, actually in the developing countries, we are still using taxation as the biggest portions of our healthcare financing. But besides that, we are still using, for example, or alternative as a personal insurance for somebody is actually rich. We also have employee benefits. We also have community financing, and we also still have the out-of-pocket. So I will explain each of this and also discuss further later. But once the country actually goes to the developed countries, the proportions of the taxation is getting smaller, or compared to other scheme. Yeah, so the biggest portions of the healthcare financing system in the developed countries is actually more of social health insurance. Besides the taxation, and also have the personal insurance and still have the employee benefit, and some of the countries actually also have the medical saving. So this is actually how the concept of the health financing mechanism. So in which that when we have the healthcare services, the financing mechanisms such as what I mentioned just now, the tax-based financing, social health insurance, and other prepayment scheme, and even an out-of-pocket payment is actually towards the healthcare financing. Actually, from where is the financing source? The financing source actually can be from the general tax, and can be a payroll, can be contributions or premium, and can be a direct payment, what happened in the out-of-pocket. So all these matters is actually need to also know where it's come from. Not just the financing source, but actually the individuals that contribute to this money. So the one that actually shows in this diagram is actually the household or individuals of the populations. So what we are going to discuss further, and how and actually what is the impact and what is actually the advantage or disadvantage of each of the financing system. So this is my own diagram when I look at a few countries have their national health financing. So most of the countries actually look at there is supposed to be an authority that looking at the fund or the health financing of the country. So the authority can be one agency, can be multiple agencies, depends on the country perceptions and how the country actually forming the system. So the funder is actually the kids. Yeah. So we have the tax contribute to the fund, individuals contribution, we also have insurance. So the fund that actually start with the small cake as a tax, but once it actually have the individual contribution and insurance, it's become a very big cake. So some of the country actually don't have only one authority, because once there is actually big cake, it's much easier to actually to become corrupted. Yeah, just imagine that we have so much money in under one agency. So it's actually very difficult to monitor. So besides from the funder, we need to look at the process of the healthcare system. So from the funder, how this funder deliver the money and how the funder actually monitor how the provider provide the healthcare. So the funder can be provide the money and also monitor the provider through the managed care organization or MCOs, and maybe also through the provider payment mechanism. So we are going to touch also about the provider payment mechanism later, okay, together with the other health financing scheme system. So this looks at the one that actually shows by Katzin in 2008. He is actually one of the pioneer in the health financing. Even my article also, I quoted him in my article about the health financing. So when you look at this diagram, we can see that actually there is not just the health system function. It's about the also health finance policy and what is the goal that we want to achieve with the health financing system that we choose. Whether we want to look at the health gains, whether you want to look at the equity in the health, whether you want to look at the financial protections, equity in the finance, and also responsiveness of the healthcare financing system. So let's look in detail about each of the health financing system. So the first and also the most popular, okay, healthcare system, health financing system is actually taxation. So actually used almost every country of the world starts with taxation. So Europe country, Canada, and Malaysia actually now, until now, still using a taxation. So the main characteristic of the system is actually both the financing and also the providers of the healthcare actually by the states or by the country. The healthcare services payment is actually given by the central level. So Malaysia, we are actually a small country. Even the UK, a big country, they are having a centralization of the healthcare financing. So then only this will actually being allocated, okay, to each of the institutions annually. So that means every year the institution will actually request a certain allocations that fits to the institution, how much the money they need, and then the higher authority, the Ministry of Finance, for example, deliver the money annually. And however, this is in the taxation, the healthcare actually always fight for with other sectors to get their allocations. For example, Malaysia, we are getting 4.2% of our GDP for healthcare. So at end of the year, our Prime Minister or our Ministry of Finance, Minister of Finance will announce how much the healthcare will get, how much is the Ministry of Education will get. So I give a few examples here. So for example, here is actually looking at the Malaysia scenario in 2022. Okay, so Ministry of Health actually getting second highest portions of the money. So Ministry of Education is actually the first. Every year, Ministry of Education is on number one. In fact, in other countries also, the portions of the cake is actually must be, or most of the time is actually higher in the Ministry of Education. We cannot say that actually it's not fair. Okay, because we need to remember, okay, the population health is not depending only from the health sectors. So we can only give the best healthcare if our population is also educated or literate. So that's why there is no, actually, it's supposed to be, yeah, the country is supposed to spend significant amount of money for the educations to make the population knowledgeable and to make the population literate. In fact, Ministry of Health can use this method to increase the healthcare of the population. For example, we give the education from the beginning of their life of education from the primary school. So that's why most of the country, they actually need spend the money to the Ministry of Education as the first portions, then only goes to the Ministry of Health or Ministry of Defense, depends on the country, and also the Ministry of Development, for example. Another thing is actually why we Ministry of Health cannot greedy into getting the higher portions with other ministry, because the population also need welfare. The population also need water. They also need a house, a good housing, for example. All that is also contribute to the health. So, however, okay, despite all this percentage of money that given to the healthcare, most of the time taxation have a problem of inequity. So why? Because most of the time with this taxation system is a dominate at the high technology urban-based healthcare. So most of the hospital, most of the facilities, most of the technology is actually at the urban area, and always deprive the rural populations. So, and worst scenario is actually when a rich people misuse this subsidy or subsidized healthcare. Yeah, so the healthcare is supposed to be fair to the affordable community, but the rich people is also queue up in the healthcare by that provided by the public healthcare. That's worse the scenario of the taxation system. The second system is a social health insurance. So it started in Germany with the Bismarck. When we talk about Bismarck health financing, it's actually social health insurance. It's actually, in the social health insurance, there is a contribution from the workers or employees or individuals. Okay, so the most of the time, as I show you in the diagram just now, most of the country in the world start with taxations, then they develop further with the social health insurance. So there is also some sort of two system in one country. First is actually taxation, and as alternative, the social health insurance. So when we look at the overall health spending, yes, growth by years in the world, it shows that actually the proportions of the government percentage towards the healthcare is actually increasing. Okay, not just the taxations, okay, but also when it's actually have the contribution of the social health insurance, the percentage of the government spending is actually increasing. This is also good for the country. But when we look at the lower income country, okay, and also the lower middle and upper middle income country, we are still stuck with significant number of out of pocket when the government don't spend so much to the healthcare. So when we look at the characteristic of the social health insurance, it must be non-profitable, and it must be by the government, and it must be compulsory to be a social health insurance or national health insurance. And the payment of this financing is actually from both the individuals and the government. The government portion may be the tax base, and there is a contribution by the individuals. In this social health insurance, most of the time, the lower income and disadvantaged individuals are given free or subsidized. Right? It's almost the same like taxation just now, but there is a portions of contribution of the individuals. And this social health insurance or this insurance method is actually there is a risk sharing because we are actually compulsory to everybody, the risk of getting a disease is actually shared between the healthy people, not just among the sick. In this, when we talk about insurance, we cannot avoid from few issues. The main issues in the insurance system is actually moral hazard and supply-induced demand. So we can discuss further about this, but I'm going to actually mention more after this with the other system. So, but we skip about the discussion about the moral hazard and supply-induced demand. So, as we know that actually the sources of the social insurance is a contribution by the employer, insured people, and also state subsidy. So, these overall expenses of healthcare or financing give a few of benefits. The first one is really cash benefits, and the second one is the health services. So let's look at one by one. The cash benefit that most of the time that we get from the social insurance is actually the sickness allowance. So in which that we have the payment of the fixed percentage of daily wage for a limited period when we are admitted. That in fact, we can also get from this social health insurance, for example, or we can give to our population is a maternity allowance. For example, the payment certain amount when they are actually during the confinement. Different countries will have different cash benefit. Okay, so maternity allowance may be given in the Australia, for example, which a few parts of Australia, for example. Okay, funeral grants is also can be given. Okay, for example, such as lump sum payment to cover funeral expenses, because some of the countries funeral expenses is actually significantly high. So healthcare benefit, however, is actually most of the country implement social health insurance actually will give the healthcare benefit. The first and foremost is actually the primary healthcare services that given by the GP as a gatekeeper. So usually the people goes to the general practitioner first, get investigated and get treated. If they are actually not well with that treatment, they only being referred to the specialist services or hospital. Okay, so in social health insurance with the healthcare benefit, usually they have a gatekeeper and also a good referral system. So the cash benefit that given besides the clinics, they also have hospital inpatient care, surgical procedures, investigations, lab tests, prosthesis, appliance, and also dental care. So in terms of healthcare benefit also, every country will have different packaging, different packages in which that how extensive the healthcare benefit they would like give and how extensive or the procedures can be given. Depends on the portions of the cake. When we look at a few countries' experience, they maybe start with a small healthcare benefit, but once they got more money, once they got more contribution, the healthcare benefit can be bigger. So most of the country in the world is actually trending or changing the process, changing to the healthcare financing from taxation to the social insurance. We can see here there is a growth of faster healthcare spending in the middle and low and also middle income country, showing that the social health insurance is actually overcome the taxation or other public financing system. And also good when we see that the proportion of out of pocket actually not that high. One of the insurance that actually, or one of the methods in the health financing that we cannot avoid, okay, and we must have as a complement in every of the country for to cater for the rich person is actually personal health insurance. So most of the countries actually using the mentality of business, such as America and Chile, and even Singapore, for example, they are using the personal health insurance. However, Singapore have more extensive in which that they have other methods that I'm going to discuss later. So personal health insurance, every country have it. In Malaysia also have it. The Indonesian also have it. Everywhere is also have it. So it started with the personal health insurance started as a complement to the taxations. So personal health insurance is actually most of the time is there by the private sectors, and most of the time is actually profit making. There is maybe a little bit about non-profit making, but I'm doubt about it. Okay, with my experience, I found out actually when they said it's not profit, but behind it is still a profitable making of the health insurance. And it can be individuals, can be a group policy. So, for example, we as an individuals, we purchase a personal health insurance as the individual policy. And in fact, when we purchase for our family, is a group policy. And for the institution, most of the time they purchase it for the group policy. The difference between the social health insurance and personal health insurance is actually there is no full risk or risk sharing. Because it's not compulsory, only who actually afford to buy, they are going to the one that actually going to buy this personal health insurance. So the risk base of the individuals is also depending for the one is actually purchase the personal health insurance. So most of the time when you have a certain disease, you need to pay more. Okay, so at the end, the risk base or risk sharing is only among the who purchase and who participate and who have a disease. Although actually the health insurance company try to minimize these adverse selections, they try to actually purchase or offer this the personal insurance to the institution, so they actually minimize in terms of the sharing of the case actually only among the disease. Why? Because if only the diseased person purchase the personal insurance, the personal insurance will have higher claims, and at the end they won't get any benefit from it or cannot get any profit from it. Okay, so what the term of adverse selection is actually more of only the individual with the risk will enroll to the insurance. Okay, who are not at risk won't buy the personal insurance. That will make the adverse selection worse. So in the personal health insurance, most of the time is only affordable people will buy it. Only affordable company will actually buy the personal health insurance. Similar to the social health insurance, the main issues among all these health insurance are moral hazard and supply induced demand. What is a moral hazard and supply induced demand is actually the utilizations of the healthcare is increased by having an insurance. So once you have the insurance, you tend to go to the healthcare, although you have very minimal symptoms. If you don't have any insurance with you, if you only have a simple cough, you won't go to the healthcare. Okay, so that's how the moral hazard happen. Okay, so that's why it actually happen in the personal health insurance and also in the social health insurance, because you know that you already purchased it. So that's why you want to maximize your utilizations. Okay, so because it's actually only by people who are affordable, so it's actually some sort like penalize the poor and the sick, and it's become very costly. Okay, and most of the time the personal health insurance also have limited coverage. It's depending on how much you pay and how depending on the packages. So there is a multiple packages of the personal health insurance. So for example, we have the personal accident insurance that covers only diseases or morbidity or mortality related with the accident. Then now people is purchasing a life insurance, in which that we try to purchase the insurance that can cover many things, yeah, together with the permanent disability, fatality, and even a nature crisis or nature causes such as floods, such as earthquake, etc. Okay. Besides that, people is also buying a medical and health insurance that covers for their medical bills, accidents, and also illnesses. So there is a few packages offered by the health insurance. Nowadays, the health insurance company is very intelligent. they actually try to increase more coverage, okay, to ensure that people actually purchasing the insurance. In fact, they also offer, for example, cash benefit when you go to the hospital admitted. What is actually how much that you will pay per day or per day of the stay in the hospital. So currently there is also health insurance offer. The contribution or the premium become an investment, for example. So in which that if you don't claim for 20 years with the insurance company, you will get for example 120% from what the money that you contribute, or 150% from what the money that you have paid as a premium. So the next method that most of the countries face is actually out of pocket. So we also cannot avoid from having a out of pocket, because most of the people need emergency healthcare. So they will actually purchase using their own money. So pays from their own income. Okay, and it can be paying to the government and also can be paying to the private sectors. So, however, in the out-of-pocket system, there is a problems of supply-induced demand phenomenon. So, in which that when we go to the general practitioners, when they know that actually we have significant numbers of money, they will charge you more. Okay. In fact, if we go for the just because of the cost, they tend to actually, because that you have the money and maybe you have insurance, so they will actually advise you to do such investigations. Cough, do X-ray, for example, but the cough not necessarily need an X-ray, but because of the money matters, because of you have money, because of you have insurance, the supplier or the provider tend to ask you to do many things. Okay. In the healthcare market, okay, what's the problem of the healthcare market? Because the healthcare market is actually imperfect. So the patients don't know or don't have the knowledge as much as the doctors. So most of the time, we as a patients, when we go to see a doctor, we expect the doctors knows what to do and do the best for us. So that's why whatever the doctor says, we are actually doing it. So if the doctors ask us to do the investigation, we just do. So if the doctors is not ethical enough, so that's why the supply-induced demand phenomenon is actually occur. So when we look at the out-of-pocket trending, between the countries, so we found out actually the lower middle income country have significant portions of out-of-pocket, similar to the upper middle income and higher middle income. So why? Because as you know, the out-of-pocket depends on your cash money. So the higher the income of the populations, actually they have more cash money, they spend more using for their healthcare. This is actually not a problem for the high income country, but this is actually going to be a problem for the lower income country. Sorry. The portions of the out of pocket when we look at the lower income, in the proportions actually significantly high compared to higher income, although the money is really higher. So why are we concerned about this out of pocket among lower income country, among lower middle income country, and etc.? So the main thing that we are concerned about out of pocket is actually a risk of catastrophic health expenditure. So catastrophic means financial hardship. So what happens if actually the people cash money is actually more than what they are able to pay? That means they spend for healthcare more for their healthcare rather than their total consumption, such as their food, their utility, their house, their whatever the consumption that they need, the important consumptions. So if they spend more for healthcare compared to other consumption, then we define it as a catastrophic expenditure. The percentage is actually around 40%. So in which that people will deprive other needs for the healthcare. Most of the people, lower income people, are actually will do whatever for their healthcare. So, however, they don't have enough money. So they tend to keep their diseases with them, and they will actually have a complication. But once they have the complications, they actually have they need to have the treatment. So once they need to have the treatment, sometimes, most of the time, they will sell whatever they have. They maybe sell whatever the house. They actually maybe get the money from the bank, for example. So in which that will actually make them poorer when they need to consume their other resources for their healthcare. That's the worst scenario that we are actually worried about the lower income country, about the portions of the high portions of the out of pocket. The next healthcare financing that we implement in Singapore that I mentioned just now, besides the personal health insurance, is the medical saving account. So medical saving account will be implemented in Singapore, China, and also US. With the complement of the personal health insurance just now. The main or the two essential component of the medical saving account is actually the saving fund. So people actually put aside of their money, okay, usually it's their income to healthcare or for healthcare, okay, and it's actually by the individuals, by the household, for example, okay, and this is actually more of a backup financing mechanism. Besides, they have the personal health insurance, for example. So it is an individual saving account that actually save purposely for the medical expenses for the individuals and also their family. That means the household head, who are actually save for that. Okay, so it's actually they can spend this money for healthcare only. So they can spend for the medical examination, hospital payment, medical payment of the all these days, for example, and etc. But only for the medical or health purposes. So specifically saving for health. Overall, from when we look at all the healthcare financing, the main barrier to all the alternative methods of the health financing just now is actually the equity issues. So we are not sure whether we are looking at the equity of what? Equity of financing or equity of geographical, for example, and equity of the income of the populations, for example. So anything that might participate change when we choose or we change our healthcare financing system. For example, now Malaysia are using a taxation. Are we really change anything if you choose other methods? So more realistically, okay, we actually try to balance certain things, and at the end we are actually towards other things. Yeah, for example, we try to balance in terms of efficiency, responsiveness, and also equity. Then we actually goes towards slightly away from the equity that we tend to put as the primary purpose of our change of the health financing system. So at the end, we need to also look at all this alternative, whether you want to take one, whether you want to take mixture of it, and what is the most acceptable by the population. Of course, in Malaysia, because we are actually started with the United Kingdom, dependent from the United Kingdom. So our population in my PhD surveys, actually they don't accept the terminology of insurance. So they don't accept the terminology of the private health insurance. So they need the populations in Malaysia more of skeptical in terms of insurance because it sounds like very business minded, very privatized, for example. So from my experience during my master's and also my PhDs, Malaysian population is accept more of national concept, taxations, and maybe a social health insurance, for example, or social health financing, in fact. So when we talk about the health financing system just now, we also have problems in terms of, we face many issues. Just now we mentioned about the equity. So when I explaining about the health financing just now, we also saw there is a advanced selections problem. There is also supply-induced demand problems. There is also moral hazards. And in fact, there is more in terms of adaptability of the healthcare system, in terms of quality of the healthcare system, integration between public and private, and what is actually the affordability of the population and affordability of the country, and how comprehensive the healthcare benefit or cash benefit that we would like to offer to our populations. So when we talk about this, we need to look at who pays this healthcare, whether it's a government or community. And if it's a government, how much? If it's actually community, how much? Okay. And if it's a community, what is the criteria we want to put? So whether it's affordability, whether it's a willingness to pay, whether it's actually how many households that you have. Yeah, what is your income? There is so many criteria. In fact, in my PhD, I'm looking at ability to pay and also willingness to pay. I found out actually there is many criteria or factors can influence in terms of government affordability and also community affordability. Then what is actually acceptable? I mentioned about the Malaysian situation in which that they don't accept insurance terminology, and they don't accept the private practice financing system. And they also asked, when I asked about the willingness to pay, they also asked how comprehensive is the services coverage. Okay, of course, if you have a small kid, you can't give so much. Okay, but once the country is grow out with the proportion of the tax and also proportion of the financing, then only we can give more comprehensive services. To ensure the comprehensiveness, we cannot avoid from having an integration between the public and private. So we know that by geographical, there is a certain part of the population is actually accessible only for the public sectors. Then some of the population actually may be accessible to the private services. So that's why the integration between public-private, or we call as a public-private partnership, is important. Besides that, we need to look at the financial system. Yeah, how adaptable the financial system to the healthcare system overall. So that's why a few of the country, when they wants to actually change their health financing, they will also need to reform their healthcare system, and to look at the efficiency of the healthcare financing, and efficiency how the money come from the funder to the provider. And just now, in the diagram shows also about the provider payment mechanism. I will going to talk a little bit about the provider payment mechanism after this, and how this efficiency of the provider payment mechanism, and what is the financial issues, for example, will occur with this healthcare financing issues. I mentioned about the moral hazard, supply-induced demand, advanced selection, risk selection, and etc., risk sharing, and etc. And who is the authority? Whether this authority hold the fund efficiently. So I also mentioned just now about the ministry. So whether this authority that hold this big case is actually Ministry of Finance or Ministry of Health, or a combination, for example. And who are going to monitor the quality? Is it Ministry of Health, or we have other body in the quality, for example, accreditations body actually going to monitor the quality. And I mentioned just now also looking about the reform. So how reform of the healthcare will also ensure the efficiency, acceptability by the populations, adaptability, comprehensiveness, and also integrations between the healthcare. So look back at the diagram that I actually come up with. So when we talk about the provider payment mechanism, we need to know how the money from the funder goes to the provider. So the importance of payment mechanism is really cost containment in terms of efficiency of this money from the funder to the provider. And also how this funder or the authority influence provisions of the services, whether we want to give incentive or disincentive for providers that actually not fulfill the standards, for example. And whether we actually would like to increase our portions or the payment mechanism is higher for the preventive rather than curative. Currently, most of the countries are still focused on the curative services. That's why WHO is actually keep actually saying that actually to ask the countries to actually spend more for the preventive rather than curative. And what is the basic health services? So how the payment mechanism will determine the basic health services. What is the packages, basic packages that we want to give, for example. And how this payment mechanism will influence quality of care. Whether it's actually the authority, we look at the technical quality, client satisfaction, for example. And another important of the payment mechanism is actually the availability of the health financing scheme itself. So we have a few payment mechanism system in the world. So we can divide it into two: retrospective payment, in which that we pay the provider upon after they give the services or claiming basis. Prospective payment, in which that they give agree they actually give in advance before they give the services. The retrospective payment mechanism is actually most of the time is actually fee for service. Fee for service is the most or the commonest payment mechanism that being used in the primary care and also a secondary care. Most of the countries are using this method. Okay, so for example, in Malaysia, in US, in Europe, most of the countries using this fee for service for their services. So most of the time, or okay, so the fee for service actually follow a fee schedules. So for Malaysia, we have a fee schedules determine the shilling of the charges. Yeah, so that is a fee schedule. So for example, if you go to see a consultant in the clinic, so how much you pay. So the consultant of the clinic cannot charge too much. There is a shilling for it. Okay? If they do investigation such as a chest X-ray, how much the general practitioner can charge the chest X-ray? Then in the fee for service is actually most of the time is not efficient or inefficient in terms of payment, because most of the time is retrospective, and most of the time the payment maybe takes time 3 months, 6 months, depending on the funder and depending on the provider. Okay, so fee for service actually prone for the general practitioner to have the supply induced demand, because they know that actually the services that they provide will be paid. So that's why they induce of using the investigation, for example, induce using such a treatment, for example, so that they can get a claim and they can get the money more. In terms of from the provider will get reimbursement on all services provided. That's why they actually purchase more or give more to the populations, and this will lead to the unlimited income related to the volume of services. So that means they will ask the patients to come and again. Okay, the follow up times may be shorter, so that many patients will come frequently, and they will get more money, and they will give more services, and they will get more money. Of course, provider will have high satisfaction, and they don't bear any financial risk, because every services that they provide, they will claim for it. Okay, they also have a high clinical freedom, because they can do anything, and they try to keep as long as possible the patient, so that they can gain money for each of the patient. So they try not to refer the patient, because once they refer the patient, they won't have the contact with the patient. The patient is actually will goes to other services rather than their services. So in view of this methods is actually claiming basis, they need to have a high administrative cost to pay to prepare for the bills for the claim. And most of the time, this fee for service is actually provide for the curative rather than preventive. For the patients, they also give high satisfaction, because you feel that how much money that you pay, that's actually what this is the services that you get. Yeah. not difficult to get appointment with the doctors because doctors love to see you. Okay, and also convenient with the long operating hours clinic because they know that they will get the services. Can change from one provider to another provider, but this will make the lack of continuity of the care because they don't care, they don't feel that actually, oh, this provider actually need to be they actually need to maintain with one provider. If they don't satisfy with one provider, they will go to another provider. Okay, if the volume is very high, the complaint and overcrowded is also maybe also high. Then a poor technical quality in terms of provider tend to overprescribe of the drugs and overprescribe of the investigations. So in terms of the funder, so although it's actually fee for service, seems like a cash out of pocket, but it's not necessarily. Okay, it can be by the insurance company. Okay, so whoever it is, the funder actually shoulder all the financial risk. So because the consumer or the patients goes to the provider will give all the services and provider will claim. So whether to the individuals or to the company. So the financial risk actually shouldered by only the funder. So high cost and cost uncertainty. So I mentioned just now about supply induced demand because you're not sure, okay, how is actually the behavior of the provider, and also high administrative cost because of the billing process. And for the funders also tends to have packages to offer to the customers, so that the customer will have higher client satisfaction and no need to have under supervision by the doctors. Okay, so in which that, for example, a package of delivery, a package of chronic diseases follow up, for example. Okay, so that is actually can be done also under funder under the fee for service. So let's look at the prospective. That one is actually retrospective. Prospective, there is multiple payment under prospective. So we can see here, there is a capitation payment, there is a global budget, and also case mix payment. So what is capitation payment? Capitation payment is actually fixed payment per capita over a period of time that being given to certain institution or provider at a yearly basis. So the capitation formula can based on the characteristic of populations. For example, the age, the sex, the prevalence of diseases. So most of the time, the provider or the institution will actually calculate how many patients that they have, at which age and what diseases, and they will actually request the money from the financier, and financier will give that portions of amount to the provider. The payment for the primary care services for the capitation basis is actually being used in the United Kingdom, Denmark, and also Holland. The capitation payment to the hospital services actually been done under, for example, in Thailand under the Social Security Scheme. And most of the time in the capitation payment method, the services actually been bundled, okay, in a year. So for the provider, so the income is actually secured, but may not be related to the volume of work because you already got the big amount of money for that year. Okay, then the financial risk actually with the share financial risk with the funder, because if you get a certain amount, but if you don't use it appropriately, efficiently, then you are going to actually also have a risk, financial risk, not just by the funder but yourself or the provider itself. There is no incentive to overtreat because you only have fixed amount of money of the cake. So if you don't overtreat the patients, you're actually utilizing the money that you have. May under provide the services because you tend to save the money. Register in low risk patients because you try to not to spend so much. So you try to actually, or the provider actually try to refer cases. So refer the high risk cases. They only keep the low risk patients so that they actually don't need to spend so much. The clinic with the short operating hours and may incline to provide preventive services because they tend to actually keep the money if the patient is actually healthy. So the patients, however, still have the high rate of will have the high rate of dissatisfaction because doctors tend to do minimal. Yeah, difficult to get appointment because the doctors tend to be reduce the follow up time. Doctors do not want to see trivial cases or complex cases because the doctors actually don't want to spend so much. Cannot change providers over a time of period because the patients the provider tend to keep them, okay, in their provision. High risk patients may find difficult to register because they tend to be referred. Patients may be referred out with the cyclist indications, and facilities not well maintained by the provider because they don't actually want too many patients to come to their services and get the advantage of however they got advantage of the preventive services. They get better in this that they don't need to spend so much about the curative services in the capitation basis. For the funder, the capitation's payment actually give a share financial relief with the provider just now, have a low administrative cost because they don't need to prepare or process the bill. They can influence the provider to locate practices in the rural area. They get the advantage of preventive services just now and more certainly in cost because that is certain amount that they are prepared and also they give to the providers to give the services. Need to find proper capitation formula so that is actually the formula can be or must be comprehensive enough, inclusive of all preventive and curative, for example, and it must be revised regularly. So depending on the population diseases and etc., and must be reliable enough to ensure that the capitation being used correctly by the provider and also by the patients. The next method is global budget. In the global budget, providers given a budget usually beginning at the year to cover all services provided. It depends on the previous spending. So, for example, the provider spend how many billion this year. At the end of the year, they will calculate how much they already expenses, and they will actually up 10% for the next year. So that is a global budget, usually found in the most public hospital in the developing countries, such as in Malaysia. So, in this global budget, however, due to actually depends on the previous spending, most of the institutions tend to Christmas shopping, or at the end of the year, they will actually try their best to finish all the money that they got from the financier, for example. With that money, they will actually show to the financier that they have spent the money and they need more for the subsequent years. That's another problem a problem of the global budget. For the providers, that's why it actually rewards the inefficient providers I mentioned just now, higher spending now to ensure the higher budget next year. These incentives for the efficient providers, so in which that providers who save money will receive less budget because it seems that you are not spending all the money given to you. Okay, so not reflective of the actual activities. For example, maybe it's not based on the bed size, for example, and the complicated cases treated at the same level of funding, for example, or primary hospital, tertiary hospital have the same amount of money, but the tertiary hospital may spend for more complicated cases. And in the global budget, because of the lump sum at the beginning of the year, so there is no bills to prepare for the claims. For the patients, the actually low patient satisfactions because providers has no incentive to keep the patients. There is also long waiting time in the clinic. There is also long waiting time for the operations, shortage of drugs, facilities poorly maintained, and under provisions of the services by the provider. So funders wise, financial risk shared with the providers, low administrative costs, no bills to cost, and certainty in the cost because they give a certain amount on long-term cost for the provider to spend. This is the most simpler and quick provider payment mechanism that actually still be implemented in many of the countries and also institutions. So the next level or the next method that actually now we are talking about worldwide is about the case mix system. What is the case mix system? Case mix system is actually classifications of patients treatment episodes designed to create classes which are relatively homogeneous in respect of the resources used and which contain patients with a similar clinical characteristic. What do you mean by clinical characteristic? So I'm going to actually give you an overview and also little bit of detail about the case mix system. For the clinician, case mix system is a complex case mix, refers to the greater severity of illness, greater risk of mortality, greater treatment difficulty, poorer prognosis, and greater needs for the intervention. So it means that the most severe cases in the case mix system shows that actually patients need more money to be treated. Conditions of the treated patients and the treatment difficulty associated with the providing of care and also resources. So for administrators, however, the case mix is actually looking at the patient's complexity, require more resources such as the money, human resource, time, and even facilities. So the resources intensity demands of the treating a patient actually shows in the case mix system. So what is the case mix system is actually aimed for? Yeah, so case mix system objective is actually to provide more objective data in which that we know how many patients that we treat, how severe and complexity of the disease is, and how much we spend for it. Okay, and this how much spend is actually spent for it is also counting all sorts of data. Okay, so the case mix also give understanding of the output such as a patient's treatment, severity of patients with morbidity or with complications, for example, and establish a relation between patients treated and also resources used, and so that the resources can be managed more effectively and also efficiently. So this case mix system first developed by the Professor Botfetter, and it started with the diagnostic related group, and it's actually revised until now we are using the ICD-10 and also ICD-9-CM. And inshallah, by next year, we are going to use the ICD-11. And we are still waiting for the WHO to come up with the ICHI to replace the ICD-9-CM for the procedure. So in other countries, they may have the different case mix system, or they name or tailor their case mix system according to their country. So in the case mix system, we need to have a few important things. Accurate diagnosis. Under the accurate diagnosis, we need to have the primary diagnosis of the disease of the patients. We need to have the secondary diagnosis. What is the content of the secondary diagnosis? Actually, whatever diagnosis besides the main reason of the admissions that patient have. For example, the diagnosis such as complication diagnosis, comorbidities diagnosis. So besides the besides the clinical coding or diagnosis, we also need to have a costing data. So costing data can be from the charges, and most of the time you are using the macro costing using a step-down method and also activity-based costing, detailed micro costing about each of the procedure, each of the treatment that we gave to the patients. I mentioned just now about the classification system. So now we are using the ICD-10 for the disease classifications, ICD-9 CM for the procedure classifications. Depends on the country. Some countries still use the ICPM for procedure for medical for their procedure classifications. So to make things much easier, or to make the calculation much easier for the case mix system, we also need to have the health management information system. We need to have the established system such as the software and also hardware. So to make sure that people can use this software, we need to train them, okay? And we also need to train the coders. So for the record keeping is also must be in the system, and this system need to be maintained. So as you know, the IT or technology is actually very expensive. To maintain such a health management information system is also actually costly. Without a support from the higher authority, the case mix cannot be implemented. Yeah, so you need to have a support from the hospital management, and we need to also show to the hospital management that case mix is also can be used for the quality assurance program such as medical audit and also hospital benchmarking using a case mix index and etc. So using the case mix system to also give to the feedback to the clinicians. What I do in my hospital, we give regular feedback to the clinician, to the clinical department, what is their performance according to the case mix system auditing. So in fact, we also can negotiate with them in terms of negotiate with the funder, yeah, using the case mix system, because case mix system is more accurate data. As mentioned just now, there is two components on the case mix in terms of patient's classification and also costing. Okay, so when we look at the disease procedure in the case mix, we have a significant numbers of diagnoses. So we have from the patient's admission, we have the diagnosis. Then we have we calculate according to the clinical pathway, for example, micro costing. Then we have the all the treatment. Okay, then from there we actually put inside the system, retrieve it, and goes to the case mix system, and we can also calculate cost, human resource cost, facility cost, and etc. Put that in the system, and at the end we can get the cost of the or cost weight of the each of the diagnosis, each of the patient's complexity of diagnosis. So from there, we actually can also request for the whether it's actually a prospective payment mechanism or capitation. So we can show to the provider, or we can show to the authority, yeah, or the Ministry of Finance or funders is actually how much we spend for each of the patients, and how much patient in such complexity of diseases that we treat over the years, and how much actually we need for the to deliver the services to the population. Okay, so this is how the case mix diagnosis will actually give rise to. So this is example. Okay, so in the concept of the case mix system, we actually looking at or measure the efficiency when we look at the input such as the resources, come up with the output of the patient's days, procedures, and surgical. And when we look at the patient's outcome in terms of what is their diagnosis with complication and comorbidity, we actually measure the effectiveness of the patients or the physician orders or physician activities in the giving a treatment to the patients. So throughout all the payment mechanism in the world, case mix actually give the almost comparable or benefit for both sides, the payer and also the provider. So what is the two method used in the case mix system? Okay, or costing is a bottom up costing and also top down costing. So however, I'm not to go detail inside in this lecture. I will go detail about this costing in the next lecture. So what is the case mix is not, yeah. So people say that actually case mix is actually cutting the budget. It's not actually. Case-mate is actually help ensure that available funds are distributed rationally between the hospital, between the complexity of the patients. And in fact, case-mate actually give a fair allocation of the resources because we calculate the facilities, we calculate the utilities, we calculate the human resource besides the treatment given to the patients. The hospital have the complex cases will receive more budget. Yeah. And it's not a tool to control the doctor. Okay. We not really control the doctor, but actually case-mate used to compare the kind of treatment doctors give to the patients. So doctors always says that actually there is a different school of thoughts. So I'm trained from UK, for example. I'm trained from US, for example. I'm trained from Middle East, for example. So when we have a case-mate, it must be a standardized method of treating a patient. Okay, so that's why seems to be a control, but it's a good thing. Yeah, doctors decide when and how to change their behavior. What is the best practice? What is the what is the standard for the country? And a case-mate is also not changing the hospital work practice, but actually examine the practice. Yeah, identify where the change might be needed. For example, when I present to my hospital authorities, I mentioned that, why is actually bed occupancy of the certain department is low? Okay, so not penalize the department of having the bed occupancy low, but actually to see what is the changes that we can do to mobilize the human resource or whatever resources to ensure that actually each of the department, each of the parts of the hospital is actually having a good bed occupancy. So, and case-mate is also not a way of removing management of health from the doctors and nurses, but actually enable doctors and nurses to see the management of the healthcare better. Case-mate is actually an excellent disease classification tools, can be used in enhancing the quality and also efficiency of the healthcare services, ensure accuracy and also relevant comparison of outcome performance in the quality assurance program, ensure or enhance the implementations and acceptance of the quality assurance program. And however, case-mate needs support from all parties, from the implementers until the higher authority, and needs a good health management information system to provide accurate and also timely data for us to calculate all the data together. Okay, so I would like to share a few of the example of the healthcare system for in the other country. So first, let's look at the United Kingdom. So United Kingdom spend significant number, but not very high, not very low of their GDP. It's around 8+%. And it's actually started quite years back in 1911, and it's actually growing up. Yeah. So UK actually start to have mixture of the financing system since 1930s. However, they have a few hiccups. They start with the workforce. Okay, then start with the social insurance, for example. Of course, with the complementary of the private insurance and out of pocket. Then they established the national health system, okay, financing system. And however, in 1987, they actually facing towards a bankruptcy. Why they face these problems? Because there is significant number of moral hazard and supply induced demand. Okay, so UK's healthcare actually dominantly public sectors, with the majority of the funds coming from the general taxation. Okay, then also have a income distribution contribution by the employee. So that is a UK's system. Look at the US or United States system. United States is really the highest country spend for the healthcare. If you look at the graph, of the percentage of GDP, US is the first or the highest percentage. They spend 16% for the healthcare. However, okay, despite their most expensive healthcare, they are not giving the best outcome. Okay, so in US, in the 19th century, they start to have this prepaid hospital care. Then they have the both private and public insurers in US. Then also they have the individuals must purchase the health insurance for their healthcare. So in which that is actually more towards the voluntary health financing system. So public fund from the payroll tax is also there to complement. So for example, they have a Medicare that's cover for the elderly and also disabled. Okay, and they also have a Medicaid, the joint between the federal state health insurance to cover for the poor individuals in the state. Okay, so in US they remain as the most industrialized country. Okay, the only things in the industrialized country, the US is actually the one that actually don't have universal coverage. Yeah, so in which that only people who have the personal insurance, health insurance, will have access to the healthcare. Looks at the Japan. Yeah, Japan is actually having the most healthiest people, the most fastest in terms of elderly populations. Yeah. So in which that they have the national health insurance since 1922. Yeah. So Japan actually have a Japanese healthcare services that covers either employees and also the government. So Korea is actually similar to the Japan. However, Korea is actually the most fastest growth country in terms of health financing. Yeah. So they also have the life expectancy significantly high. Okay, and they have remarkable in terms of health financing method. So it starts with the 1977 compared to the Japan 1922. So and within 12 years, they already achieved universal coverage. And they have four major scheme, employed workers in the industrial and so commercial enterprise, government officials and so private school teachers, self-employed groups and also medical doctors in urban areas, and also self-employed persons in the rural areas. So all this scheme is actually coordinated by the National Federations of Medical Insurance. Is a national health insurance for the country. So they have the benefits such as cash and also healthcare, and they also have the per diem and also have the allowance. Okay, but they also have the co-insurance and so co-payment for certain services that they provide. The payment to the provider, they use a fee for service for the both primary and also hospital care, but it's actually also have the medical fee review committee. They look at the fee schedules regularly. Taiwan also have universal coverage. 1997, they have single payer scheme that is under Ministry of Health Taiwan, and they also have the individuals and employer contribution depending on the percentage of their salary. So Taiwan is also offers a benefit for the healthcare benefit and also a cash. And the provider is actually have a contract with the National Health Insurance Bureau, and they also give fee for service for both primary and also hospital services using a fee schedule. So, however, in the in the Taiwan, they have a problem in terms of health expenditures increase from the 3.3% until 5 to 5%. And there has also problems in terms of medical claim. Okay, similar to the UK, because of the free riders, that means the people don't pay, but they also purchase the healthcare or get the healthcare free. They also have a problem of the moral hazard, and they also have a problem in terms of fee for service payment to the provider. So I think that's all in terms of the health financing in general, and also payment mechanism in general. So I know it's actually quite lengthy, and it's actually so many things actually I need to deliver. So I try my best actually to cram it and try to give as general possible for us to trigger for the discussion. any questions and also any discussion.
Okay, thank you, Prof. Azimatun. I think it's very interesting explanation about the healthcare, especially for the case mix approach, yeah, Prof. As
Yeah.
case mix approach is quite new for me, yeah. Quite new because in Indonesia maybe case mix can try to implement it, yeah. Because in Indonesia a little bit have a problem about the healthcare budgeting. So
Actually, Kesme is started in Malaysia, but it's fully implemented in Indonesia.
Oh, really, Prof?
Yes. So we signed MOU between the Indonesian healthcare ministry in 2014.
Okay.
Yeah, so Indonesia now is actually the biggest country in the world using
Case mix.
case mix system.
Oh, I don't understand about this, Prof. I'm sorry, Prof.
It's okay.
Okay, any participant of this event have a question or confirmation, please raise your hand.
Yes. I would like some opinion and also maybe questions. I will share the slides later because previously the slide is actually 100 plus, but I tried to cram it to the lesser. That's why I actually delay in terms of delivering the slides to the Miss Ratna.
Ya, thank you, Prof. Teman-teman sekalian, mungkin kalau tidak bisa berbahasa Inggris kurang gitu ya, silahkan dalam bahasa
boleh,
ya,
boleh.
tidak apa-apa. Boleh.
Boleh, bisa. Ya, ada sebarang soalan?
Silahkan teman-teman. For me, it's quite interesting, Prof, because in Indonesia, I just understand or know that cash mix is one of the country, the biggest country is Indonesia that implemented for the system. So,
Yes.
can I want a question, Prof, about the cash mix approach? What is the fundamentally different between cash mix and the traditional system, Prof?
Between again?
Cash mix, and the other.
Okay, the main difference is actually we in the case mix we managed to calculate. So using a case mix, as I mentioned just now, every patient that admitted to the hospital or treated or seeing the doctors or healthcare facilities, their record or their data will be recorded, and this data recorded will actually be analyzed or being coded using a clinical coding. Then after that will be merged with the costing data. The costing data is actually measuring the cost of each of the resources. So for example, we cost the facilities, we cost of the hospital, and how much is actually per square feet of the hospital we spend for each of the patients, for example, and how many minutes of the doctor's salary is actually spent for the patients, for example. So all that actually will merge together, and at the end we come up with what is actually the cost per patients with per diagnosis. So we know that, for example, just patients with the cardiac disease, treating with the drugs, treating with the operations. So how much we spend for that particular patients. So we can actually show to the provider or we can show to the funder that this is the numbers of patients that we treat. This is the numbers of our RM, the one that we spend. Then it's actually more extensive or more accurate costs actually being measured. So previously, or other method is just estimate. So for example, we estimate, we have how many patients, but we don't really look at their diagnosis. So the primary hospital may claim that they treat how many thousands of patients, but maybe because the primary hospital, so they treat thousands of hospital with the simpler cases. So when the simple cases will need simple resources or less costly compared to bigger hospital or complex hospital. So previous method, they can just based on the numbers of patients or numbers of populations. They don't look at the complexity of the diseases. So that's the main difference between the case mix and also other payment method or other case mix, other system.
System. Okay, Prof. Maybe in Indonesia, case mix like for the calculate the PPJS, yeah. In Indonesia have insurance, yeah, PPJS, yeah, because there are two system, yeah, in Indonesia, PPJS or no PPJS, yeah.
Yes.
Maybe the PPJS is the case mix, I think, yeah.
Yeah. So we actually have good collaborations with the PPGS. For example, I'm contacting Prof. Ali Kufron, the president of the ABGS. Yeah.
Yes.
So about the case mix, clinical coding and costing and etc.
Okay. It's very interesting to me, Prof. I think it's new insight because PPJS is like in Indonesia quite different with the no PPJS, yeah.
Yeah.
Especially for the give a treatment, give for the patient is very different because the PPJS have classes, yeah. The level, third level, second level, first level, like this.
Yeah.
Okay, maybe the other participant, teman-teman yang lain, ada yang ingin ditanyakan atau ingin ini menarik ini teman-teman semua. Karena
ya mungkin
di
ada yang mau bertanya tentang insurans ke?
Nah, itu dia.
Tentang insurans, saya juga sering diminta ataupun sering dipanggil oleh insurans company. Ya. Saya pernah ditanya oleh insurans company, jika ada case mix ataupun kalau ada social insurance, apa akan jadi kepada private insurance? Mungkinkah mereka akan bankrupt contohnya, ya? Sebenarnya kalau lihat pada Indonesia punya scenario, dengan adanya BPJS pun, ya, tetapi insurance company masih boleh grow, ya. So sebenarnya dalam financing ini tidak ada sesiapa pun yang akan bankrupt. Cumanya adalah insurans mungkin akan membantu kepada orang yang lebih kaya untuk mendapatkan fasiliti yang lebih baik. So jadi case mix ataupun finance social health insurance, for example, taxation is actually untuk orang-orang yang tidak berupaya membayar dan orang yang miskin, orang yang susah kerana banyak penyakitnya dan sebagainya. So saya juga diminta menasihati ataupun insurance company juga memohon saya untuk memberi pandangan bagaimana mereka mahu membuat duit contohnya. Jika ramai yang sudah ambil BPJS contohnya. Tapi ada banyak cara, ya, ada banyak cara dan mereka masih boleh membuat duit, ya, tetapi tidaklah sehingga membuat duit itu hingga menekan orang yang susah gitu. Ya, jadi kalau mahu buat duit ataupun mahu berniaga, biasanya dengan orang kaya gitu.
Okay, Prof. Okay. Because one of the interesting in Indonesia, the people of Indonesia prefer medicine in outside Indonesia, Prof, like the Penang, Singapore, better than in Indonesia. Itu. Jadi itu yang menarik karena ketika saya ke Penang ya, I went to Penang, 80% like the Glen Eagles Hospital, kemudian Island in the Penang Island Hospital, 80% from Indonesia, Prof.
Yeah.
The patient is very interesting because in the mindset of Indonesia, BPJS is quite lately mendapatkan kualitas pelayanannya itu biasanya agak lama untuk obatannya, medisinnya menjadi berbeda seperti itu.
Ya.
Agak dibedakan. Itu mindset ya. Sebenarnya sama saja ya, Prof ya.
Kalau pengalaman saya pergi ke Indonesia sendiri, saya sering ke Indonesia kerana ada kolaborasi dengan beberapa universitas di Indonesia. Sebenarnya mindset tu satu, tetapi mungkin apa yang perlu dilihatnya adalah fasilitinya. Kalau di Indonesia sering dikatakan yang public facilities itu kurang memuaskan. Private university itu lebih baik contohnya, mungkin kerana tidak ada begitu tinggi persaingannya antara public dan juga private itu. Walau bagaimanapun di Malaysia tidak semestinya private hospital itu yang terbaik. Di Malaysia kerana ada persaingan antara public dan also private hospital ataupun facilities, so the facilities being provided by the private and also the public is actually quite equal. We are also competing in terms of quality services that we provide. For example, we are also in terms of each of the institution, whether it's a public or private, we are going for the accreditation body. Of course, provided that private provider that actually have more money, they will go for the more of international patients. So they actually goes for the JCI, Joint Conventional Incentive, institution body for them to get more international patients. So they actually invest in the health tourism. So that's why I think quite a significant numbers of patients from other countries comes to Malaysia. So they really invest for the health tourism. So our main clients is actually from Indonesia and also Middle East.
Okay, Prof. Maybe there is no question for the participant.
Okay, never mind. I think if they actually have questions after this, they can list down the questions. They can also ask me on the 3rd November, the next session with me.
Yeah, Prof. There is one question
in
the chat box.
Di Indonesia, ansuri BPJS dan tunai, kenapa bayarannya terlebih dahulu yang tunai daripada yang di BPJS? Padahal BP juga kira bayar insurans setiap bulannya. Okey. Sebenarnya seperti dalam lecture saya tadi, kalau yang out of pocket memang cepat. Kerana itu keluar cash daripada poket kan. Jadi apabila kita keluar cash daripada poket kita, jadi pelayan kita itu memang dapat segera duitnya. Jadi kalau menggunakan insurans, sama ada personal insurance, sama ada social insurance, macam BPJS adalah social insurance Jadi ini ada melalui beberapa proses tapisan gitu. Dia ada banyak tapisan, itu satu, dan keduanya adalah cara pembayarannya. Jadi dia perlu menyemak dahulu sama ada orang ini sesuai atau tidak mendapatkan perawatan mengikut BPJS punya guideline. Kemudian jika sesuai barulah diberinya pelayanan itu. Kemudian apabila diberi pelayanan itu juga, dia akan mengira adakah pelayanan itu boleh perlu atau tidak diminta penambahan keuangannya. Contohnya co-paymentnya, for example, ataupun adakah pesakit yang pergi kepada hospital tersebut yang menggunakan BPJS willing to pay more for extra services, for example. If not, they will only cap at the BPJS punya packages ataupun services yang telah ditetapkan. Kemudian daripada ini, mereka akan claim ataupun menggunakan case mix system dan sebagainya untuk mendapatkan payment balik kepada provider tadi. Sebab itu di mana kalau kita compare in term of fast of the delivery between out of pocket dengan financing system yang lain, memang out of pocket itu adalah yang tercepat, the fastest compare to financing system yang lain. Jadi kalau tengok daripada segi kecepatan itu memang tidak boleh dinafikan. Walau bagaimanapun kita melihat kepada konsep yang lain. Contohnya tadi kita mention tentang jika dibayarkan tunai itu, tidak semua orang ada duit di dalam poketnya. Jadi kita melihat keseluruhan itu.
Oke, seperti itu ya. Like this for the question from Ratu Cendana. Cendara ya, Ratu Cendara.
Ya. Terima kasih Ratu Cendara. Adakah saya menjawab soalannya? Am I answered your questions?
I think clear, Prof.
Thank you very much.
Okay.
Is there any questions?
Okay. If no question anymore, maybe the session or the event. Thank you, Prof, from the Ratu Cendara.
Ya, sama-sama.
Okay. Thank you, Prof Azimatun, for the explanation about the first session, because we have a second session, Prof. And the next Friday we join for the healthy budgeting, healthy budgeting.
So I will cover about the healthcare budgeting, and I'll also try to cover a little bit about the healthcare cost analysis.
Yeah, okay, Prof. Okay, all of the participants, we can join again the next Friday. I think the more interesting theme like this healthcare budgeting, I think is very, very quite interesting for us to know about the Indonesia healthcare system, gitu ya. So thank you very much, Prof Azimatun, for the explanation. Thank you very much for all of the participants in the e-lecturing international class. We can join in the second session in healthcare budgeting the next Friday. Thank you, Prof.
Thank you very much to all.
Okay.
Bye-bye.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Mencoba menjadi seperti yang engkau minta, Aku tahu engkau sebenarnya tahu, tapi kau memilih seolah engkau tak tahu. Kau sembunyikan rasa cintaku di balik topeng persahabatanmu yang palsu. Kau jadikan